Well, first want to start by truly welcoming each and every one of you. Thank you for joining us on this Saturday morning to spend this time with us. We're really, really grateful to all of you and to our speakers for joining us and for making this all the more special. My name is Romero Santiago, and one of the board members for NECOM, part of the Education Planning Committee. I finished my training at Yale's program. And I will be joined as a co-moderator with my colleague, Kevin Lutchman, who we trained at the same medical school, actually. And he's a faculty at Harvard's program, trained there as well. So we both look forward to moderating this session. And I will be moderating the first half, and then my colleague Kevin will moderate the second half. And so just wanted to, truly welcome not only our fellow clinicians in OEM, but also our non-clinicians who work here with us. This is the second annual toxicology seminar that we are hosting as an NECOM MARCOEM partnership with the Hopkins ERC. And the reason we realized this kind of event was important is that in our field of OEM, the environmental medicine piece is really broad and includes so many dimensions. And we partner with so many colleagues, from industrial hygiene to safety professionals and other management services and attorneys and so forth. And so we realized for this that it was really important to have a forum where not only the clinicians, but all of the staff and non-clinicians that we work with hands-on in a hand-in-hand fashion are all here together. So we're truly grateful to all of you for taking the time to attend. And what I will do is I will monitor the chat, and in terms of questions, once each speaker is sort of finished, I'll help moderate those questions. So please do think of those as the presentations proceed. And so without further ado, it is truly my greatest honor to be able to introduce our first speaker of this half-day seminar, Dr. Rose Goldman. So Dr. Goldman, she's an associate professor of medicine at Harvard's Medical School and also associate professor of environmental health at the Harvard T.H. Chan School of Public Health. And she started the OEM health program at Cambridge Hospital, now Cambridge Health Alliance, and the founding chief of the division of OEM until 2010, and progressed in her career to include not only OEM but also the involvement with the pediatric environmental health issues and the PESU, as they call it, the Pediatric Environmental Health Special Unit for New England, and has been very involved with climate change and health effects as well. And she also has a particular focus on clinical environmental / occupational neurotoxicology, particularly metals, heavy metals, for 40 plus years with numerous publications. And so it's very timely that we have her speaking to us today about copper toxicity. And so without further ado, please join me in welcoming Dr. Goldman.
Thank you very much. I hope everybody can hear me okay. I want to say it's really great that you put together a conference like this, bringing all the people from different spheres together. And as many people know, metals and toxicology has been one of my favorite areas. And I'm really delighted that I can share with you one that I never got involved in until the last couple of years, which is copper. And I think it's sort of been ignored, at least I was ignoring it, until three patients over the last couple of years have really educated me about it. And I thought I would share what I've learned with all of you, and also with some practical take-home points. So I'm going to try to upload let's see, here it is. And I'm just going to put it in presentation mode. Can everybody see that now?
Yes,
Okay.
yes, we can. Thank you, Dr. Goldman.
Okay, great. So then I think we're ready to roll. And can you just remind me, when does my session end? Because I want to be sure to leave plenty of time for questions.
Officially we're starting a little early. Your session, we officially had as endpoint as 9:15 a.m. So
okay, so yeah. We'll try to have, I think there's plenty of time.
Yes.
And we'll have time for questions. Okay, so let me get rolling here. Let's see. My only disclosures is I write for Up to Date, but it turns out not on copper, and I get royalties for that. I'm on a committee for a little startup, Satya Technologies, and these are only my opinions, not those of Cambridge Health Alliance or Harvard. I actually didn't write up the learning objectives, so let me just say what I hope we're all going to get out of this, which is I want to share with you what I've learned about copper. And I think it's really important that we understand what happens and why with copper toxicity or too much copper. But there's also a problem with too little copper. And to understand about that, and it's sort of like the three bears, you have to have just the right amount. Um, so I want to start where copper sits on the good old periodic table. And you will see it. I don't know if my arrow, can you see my arrow when I move it in? Can you see it? Okay, great.
Yes, yes, you can.
Okay, so
Yes,
here's
yes.
copper, and it's sitting right next to zinc, which we're going to talk about, and cobalt and iron and magnesium. And what's interesting about these, I'm not sure about nickel, is these actually have a role in the body, an important function. They're an important element for bodily functions, which we'll talk about. And so, in some ways, copper is different from these guys over here, are sort of villains, lead, mercury, arsenic. There is no normal amount of those metals in the body. So anything that we find in the human doesn't belong there, and it's a matter of figuring out at what level they cause trouble. With copper, we have an issue because what we're going to learn about, I'm going to go through some background information before we jump into the cases, that copper actually has a lot of important functions in the body. And so we have to be aware of that in terms of our assessments and our recommendations. So it's an essential trace element. I'm just going to provide a little background info that I think is going to be helpful when we jump into the patients. First of all, it is a natural occurring metal in soil, water, rocks, and we have to have a certain amount of it. And so one can argue about RDA, the recommended daily amount. For adults is somewhere around 900 micrograms. And during pregnancy and lactation, 1,300. And then there's some discussion about what really would be an upper limit for an adult, but people might get sick at different levels. It's been put out there something along the idea of 10,000 micrograms in a day. And I'm putting it in both units because sometimes we see things written in milligrams and sometimes in micrograms. And the dietary sources comes from a lot of plants and animals, particularly liver, and we'll find out why, because copper finds its way to liver, shellfish, mushrooms, seeds and nuts, whole grains, chocolate, another reason to eat chocolate, and drinking water. And so those are some of the sources for copper. And so why is it important and why are we even talking about copper? So it turns out it's a cofactor for many enzyme systems that allow us to function, particularly a number of the energy production redox reactions. Some of you might remember from biochemistry or not, mitochondrial oxidative phosphorylation, iron metabolism. Remember, it sat there very close on that periodic table to iron. Connective tissue synthesis, neurotransmitter synthesis, myelin formation, and many physiological processes involve copper ion enzymes, angiogenesis, neurohormones, gene expression, brain development, the immune system functioning, defense, particularly defense against those nasty oxidative species and which cause damage. And there's a copper-containing superoxide dismutase that helps to contain that. So frankly, I had personally no idea how important copper was in so many different functions. Now, I'm not going to go into great detail, but the whole system of how copper gets absorbed and goes out is quite fascinating and also relates to both the toxicity and the issues with deficiency. And I'm just going to quickly just go through a few points here that will be relevant as we go to the cases. So first of all, the other fascinating thing with copper is it has a lot of various transporters, and I love the phrase metallo chaperones to take it around. But basically, it first comes into our gut through ingestion, and then there's one transporter that starts to move it into the intestinal cells. It goes through the intestinal cells, and it sort of hangs out there for a while with metallothionein, which is quite fascinating because that protein helps to rate how much copper we should be absorbing. If there's a lot of copper, it will absorb less, and if there's not enough, absorb more. So when you try to look at how much copper do we absorb, it's actually a very dynamic process. And then it has to come out of the enterocyte and into the blood. And here's where we have one of our genetic problems, which is Menkes disease. And this happens that this gene doesn't work, impacts this copper ATPase, so it's not getting the copper into the blood. And this is a condition where people have deficiency. Anyway, then it's bound. There's some debate bound to albumins, ceruloplasmin, but basically it then gets transported to the liver. And very little copper is sort of hanging out that is not bound. And in the liver, it now undergoes metabolism. It's taken up by the hepatocytes and it binds to ceruloplasmin there, which is sort of this temporary storage site. So you can understand why eating liver gives you a lot of copper. And then anyway, it's then released from the hepatocyte, and that's another gene here. And when that gene is impacted, you get Wilson's disease, which some of us are familiar with, which is a copper storage disease and excess copper, too much copper in the liver, the brain, with many adverse outcomes. Anyway, from this point, there's what's called complex trafficking systems, which we could spend hours and hours on those, but basically taking the copper to get delivered to the various enzymes and systems where copper will be joining and facilitating enzyme actions. And I love some of the names that they give to these, quote, trafficking proteins, calling some of them metallochaperones. Um, anyway, then what happens, whatever copper is left over that hasn't been bound and put to use, then binds to this metallothionein, and that is what comes out for elimination via the biliary tree and the feces. This whole plasma half-life is somewhere in the order of about 24 hours. And the fascinating thing is that when you look at how much copper in a healthy person is taken in and excreted, there's not a lot left over or built up. So it's a really fascinating, complex system for how our body is handling copper, and it is interfacing with other elements, which we'll talk about later, particularly zinc. Okay, so that's the background. Now I'm going to start with patient number one, who's 1 year old. And it's sort of, the story could also be named The Birthday Party from Hell. So it was a beautiful little birthday party for this 1 year old. And there was a magnificent cake that was made by a local bakery. And you can see how gorgeous this cake looked. However, something happened afterwards. Within 20 minutes, the little 1 year old started vomiting, had 6 episodes of non-bloody vomiting. She also had some diarrhea. Other guests started having GI complaints, throwing up, having diarrhea, and even the dog got sick. So the next day, the patient with her parents, of course, saw the pediatrician who thought this could be food poisoning and called the regional poison center, who advised calling the local Department of Health. And here, by the yeah, I'll just point anybody that wants to read about this. This had come to our Poison Center and Poison Fellows, and was written up in collaboration with the Department of Occupational Health. So it was another great example, by the way, of collaboration of different professionals. So the Department of Health came in and actually interviewed the various people at the party and figured out that it was only the people who ate the icing who got sick. They looked at it for any bacteria or infectious agents. There were none. And then they went back to the bakery and examined what went into the beautiful icing, which was a gold luster dust, which did say non-toxic, but it also noted that it was non-edible. And it turns out it had copper in it, which gave it that beautiful rose color. And they did some analysis and they estimated that there was about 900 milligrams of copper per slice. And just to contrast that with how much copper you would get if you ate 4 ounces of liver would be 17. So it is getting up there, and certainly for some people could cause copper symptoms. So, and actually, as we're going to learn, having too much of copper at one moment like that will cause throwing up and diarrhea. But then the story gets a bit more complex, which was 4 days later, the parents now also called their primary because they thought the child looked listless and wasn't eating and seemed to have a facial droop. And so now they called the Poison Center, and at that point I was taking call for our pediatric environmental health specialty unit. And even though I'm not a pediatrician, I do take call for environmental exposures. And so I got called, usually happens on Friday night, and with the question, does this child have, is this symptom related to copper poisoning, which they knew the child had from earlier in the week? And does this child need chelation? So I'm going to say people can think about that a little bit and write something in the chat. I can't see the chat, but maybe we'll circle back around what people's thoughts were. Although if somebody has a really great idea, Romero can chime in on that.
Sure.
If you want, before I tell you what I thought, I don't know if anybody had an idea.
Yeah, please feel free to place it in the chat.
So here's the question. Would somebody who had acute copper poisoning earlier in the week develop a neurologic condition later on? Is there anybody who has something they wrote in, Romero?
So far, I'm not seeing anything.
Okay, so we'll move along and we can always come back to that. So I heard the story and I was pretty doubtful about it because what I knew about copper is you had this acute syndrome, but you didn't have something delayed once you recovered. And I was concerned something else was going on. So I referred her to the emergency department that was near them, and we had conversations later into the night. And basically, the emergency department evaluated the patient. She had normal vital signs. Her physical exam was actually quite normal. They did not appreciate a facial droop. So, of course, they did the usual workup. Complete metabolic profile, sodium, potassium, BUN, creatinine, all that blood count, and also drew a copper and ceruloplasmin. And they did a nasal swab, and lo and behold, it was positive for rhinovirus and enterovirus. So it looked like what she really had was a cold, but she was admitted for observation because of this copper history and concern that maybe something else was going on that we weren't appreciating. So on hospital day 2, the serum copper level came back at 97. And again, with reference levels, I'm not sure if these are really pediatric reference levels, because a lot of the time we certainly learned that with aluminum, the reference levels are not necessarily those of children. But anyway, the copper level was within the reference level, and I'm not quite sure even if it's serum or blood. The ceruloplasmin, you also have to be measuring because there's a interaction between the copper and the ceruloplasmin, which was 22, which was also normal. And based upon some studies with patients who have Wilson's disease, there is a formula which you see below, which you can use to sort of calculate what might be the free copper still floating around. And the Tox Fellows did that. And they came up that her free estimated copper was still a little bit high, but certainly nothing that would cause great concern or make us think that any of this current symptomatology was related to copper. So 1 month later, she was completely normal, and her parameters of copper, ceruloplasmin, and estimated free copper were all normal. So I think this patient is a great one to start to talk about acute copper poisoning. And actually, Alan Wolf, another pediatric toxicologist, once told me that in terms of this patient who we wrote up on that reference, that before there was Ipecac, people used to give some copper to make them throw up. Um, but whatever the mechanism is, it's not 100% sure, but it seems like if you have too much copper at once and you overload the system, you're going to end up creating reactive oxygen species, causing cell damage, and reactions that lead to some kind of mitochondrial dysfunction. And particularly, there's a gastric irritation. As you recall, copper is coming in and going through this complex process to go through the enterocytes. A lot of irritation. Usually copper, you can be in the elemental form, but it's also in cuprous and cupric forms and tends to bind with other agents, and typically something like copper sulfate. So that's going to be irritating to the gastrointestinal tract and prompt this symptom of vomiting, abdominal pain, and diarrhea. And by the way, the reason the dog got sick is that some people fed the dog some cake, or he got into the cake. Um, if there are really more serious cases, which are very rare, you can actually get GI bleeding. And because these carrier proteins are carrying the copper to the liver, you can get potential hepatotoxicity that can lead to methemoglobinemia and rhabdomyolysis and even hemolysis. It's very, very rare to have that kind of copper poisoning. But I think the takeaway from this is that the most common thing you see is the throwing up and diarrhea, and usually that resolves. Um, so basically, the treatment is like what we saw with the first patient. Fluids, replace the GI losses, symptom management, look for laboratory um, studies that are going to assess for potential dehydration or even end organ damage, chemistries. Our patient had normal liver tests. Um, the copper, sometimes it's blood, sometimes it's serum. It always seems to be a little confusing, even with our lab, which one we're getting. And the ceruloplasmin, which is the most a common carrier protein that also is binding with copper and reflecting how much is there. Uh, Questions: should we be doing decontamination? And looking in the toxicology books, not really, because in this situation, there's so much vomiting that it eliminates most of it. They don't think that there's any value with activated charcoal, which is sometimes given. I would have concerns about that also in the terms of somebody throwing up a lot. You're worrying about aspiration. Um, and chelation is really also not really done in these usual cases where you don't have a problem with a genetic condition. Most chelation therapy is in the Wilson's disease patients who have a lot of storage with copper, and the most common chelator given to them would be D-penicillamine. So where else do we see acute copper toxicity that might come up? Well, I don't know if any of you have ever had this drink called the Moscow Mule. I myself have not had it, but apparently it is served in a copper mug. And it turns out that one of the things that releases copper from wherever it's sitting or bound is acidic. We see that with other metals, which is why there is a problem with an acidic environment with lead pipes because it's going to leach lead out. And in a similar fashion, if you're exposing the copper pipes, a cocktail thing to an acidic environment, then you can release the copper from the lining and actually cause people to have throwing up. And you can imagine some cocktail parties where people start throwing up. And there was actually a case report of nurses drinking, a group of nurses who were drinking some kind of drink in a mug like this and also had this problem. And in some departments of public health, they're actually either advising or banning the serving of cocktails, which the alcohol tends to be acidic, in a copper-lined cup. In terms of workers, we do occupational health, where we see some acute or subacute chronic, it's more chronic exposures, certainly in a copper smelter where the exposures would be dust and fume. Mostly with workers, we're seeing a problem with skin irritation, nose and throat irritation. In some reported cases, there have been pulmonary reactions, and with welders, there's a zinc oxide fume that can lead to something called metal fume fever, where somebody gets a cough, chills, chest pain, fevers, and they look like they have the flu, but it goes away in a day or two, and that's called metal fume fever. So if you're doing a kind of welding with copper that generates copper oxide, the worker could get a condition something like that. So then, so we're going to leave. That's, I think, the crux of acute copper. And the takeaway there is most of the time it's from ingestion and it's nausea, vomiting, diarrhea, and usually without a neurologic sequelae in those situations. Of course, Wilson's disease is different because they're chronically overexposed to copper. Well, what about chronic copper intoxication? Where do we see that? And of course, we've learned a lot from people who have Wilson's disease, which is this impaired function of that intracellular copper transporter that from this gene, the ATP7B. And in this situation, they are not excreting copper, which is the big problem. So it accumulates in the liver, the brain, the cornea. And when you do testing for them, a classic, but not always the sign, is the very low ceruloplasmin. And there are other tests for Wilson's disease. So we're not going to dwell on that, but that is the classic situation. But most of us who do not have problems with our transporting transporters don't have this issue of accumulation. But what about excess copper exposure, and particularly from drinking water? And this leads into the public health sphere about how do we know how much copper should be in the water, and what happens when patients get a report of high copper levels in their water, and then their concerns about it, and how do we address those concerns? So that brings me to the second patient that a patient and her mother that I was dealing with about a year ago. And so she's an an 18-year-old female, and her situation is she had chronic hives, and she also had elevated liver transaminase, the ALT. And her main question was she wanted to know if these problems were related to the high copper levels in their drinking water. So she eventually came with her mother to see me in our occupational environmental medicine clinic. And this is the story that we got. And she was 18 when she came to see us, so that's why she didn't go to the folks at the Pediatric Environmental Health Clinic. So, what she and her mother told us is that when they were 6 months old, she and the family moved to an apartment that had copper pipes, but they got the water from a well. And they actually lived there for many years, and they just moved from that place 1 year before I saw them, which was in 2025. So many years at this location. So the story of the copper started, according to the mother, really around 2015 when she saw one of the copper pipes under the sink that was sort of corroded. And so the pipe got replaced. And going back in time, she remembered that they had the water tested in 2009, which is common for when we have a well. And she knew the report said that it was very low pH, but there was no metal testing done at the time. So fast forward to the summer of 2023, and she, for some reasons, was really concerned about copper in the water, maybe because the water was turning a funny color. So she had the water tested from the outside hose, and that had a normal copper level. But you could see that the pH of the water coming in from the well was quite acidic at 6.9. Inside the house, the pH was 6. At that point, though, she did have the copper tested, and it was 0.65, so it was considered okay. So she replaced the water filtration system, but nothing was done about this low pH. So 1 year, about 6 months later, she continued to be concerned about her water, and she retested the copper, and now it was 2.1. The pH was still quite acidic, and she got the report saying that the copper level was high because the EPA action level was 1.3. So this made her get very concerned. People go on the internet and read about copper, and she was very concerned about particularly her daughter with the hives, and maybe this is why she had hives. And she took her to the doctor, who then got either a blood or serum copper level, which came back elevated at 232 with a reference level 71 to 145 for that lab. And her liver enzyme was, the alt was 38, which is above that reference range of 5 to 32. And for the non-physicians, a lot of us wouldn't get too excited about a 38, but anyway, she was very concerned that her daughter was now having liver toxicity from this copper. And they stopped drinking the water then. And a month later, her copper was already going down. And the daughter, if you asked her, maybe thinking back to that time, said maybe she recalled that she had some low-grade stomach issues. Anyway, at that point, the family had stopped drinking the water, and they moved out anyway from that apartment about a month later in July of 2024. So the mom continued to be concerned, looking things up, wondering if she should have natural chelation. The daughter had hives. But then what happened was um, uh, in April of 2025, her copper level, she kept watching it, was actually down and was normal. However, What also happened in April 2025, she got ill with the tonsillitis. She got on antibiotics. She had a lot more hives, and now she had an abnormal liver function of 148. Interestingly enough, when we went back and we had to chart all of her numbers, her serum copper level was actually normal at 109. But the mom was now very concerned that this abnormal liver test was related to all those years of having the copper in the pipes, even though the copper level at that moment was 109. But when you spoke to the daughter, the hives actually weren't necessarily related to when the copper levels were high or low. It seemed to be more precipitated by whenever she got sick or many other things, stress. Nobody ever figured out why she had chronic urticaria, and who knows, she may have an underlying immuno problem. In any event, we saw her not right then because she was graduating high school. So we saw her as soon as she finished graduating high school in June 2025. She basically had normal vital signs. You can see she was a bit overweight. She had a normal physical exam, including her skin. She didn't have hives then. And so we did the usual tests, BUN, creatinine, liver function tests, and in our lab, the alt was 40. She had a reference range 12 to 4. Our reference range was 12 to 45, and her serum copper was within the normal range, as was the ceruloplasmin. Um, and it turned out she had had a ultrasound of her liver previously, and it showed some fatty infiltration. So the mother is still concerned and wondering if there's any long-term effects from copper. What about the previous abnormal liver tests? And still concerned maybe there's high body stores. Should she get chelation? You know, you can go to some alternative providers who are always advertising chelation. So I don't know if anybody wants to chime in here on any interpretation or advice. Um, they have any comment or question,
Mhm.
but I'm going to
Mhm.
tell you what my interpretation and how I dealt with the patient.
Okay. Yeah, not seeing anything in the chat so far. If
Okay.
there's anything, let me know.
Okay. Well, we'll have time for questionings. Anyway, my approach in these situations, you know, what happens is, and I'm just going to go back to remember one thing, this EPA action level of 1.3. And so what happens that we see, and I'm sure some of the other clinicians and probably the industrial hygienists and nurses, everybody sees this happen. The patient gets a test of their water or their blood, and it's above whatever the regulation is. In this case, it's 1.3. It could be the water that at the school is instead of the EPA level of 15, it's 18. And they think everybody's going to get neurotoxicity. And so, which you don't want it that high, but, and of course, there should be no lead. But the question is how we interpret these levels. And um, over the years, I've gotten more and more involved, or I should say, trying to understand where these levels come from, and to use that as a way to help the patient understand it and to help them understand why this may not be causing all of the problems that they are concerned about, or some of them. So I did a deep dive into this, and a good starting point for a lot of this is to see what the population level is. And that's sometimes where reference ranges come from. But we have to remember that being above the population level doesn't mean you are in a toxicity realm. And so if we look at the NHANES studies, our CDC at that time was collecting this fantastic surveillance data of many metals, lead, mercury, copper, many, arsenic, and we can go back and see what the population levels are. And they do have one for ages 12 to 19. But I will say they don't distinguish between female and male, and there could be some differences. This particular patient was also taking birth control pills at some point. So you'll see that that mean copper level in the population is about 106, and the 95th percentile, the top 5% is 153. So if we look at her results when she had a 232 and a 202, she's clearly above the population level. But the question is that related to this water that's mildly elevated at 2.1? Well, could be, but in the end, we don't know, but maybe. But then the other question is, did that level of 2.1 milligrams, so maybe she was taking in 4 milligrams a day, would that cause some local GI discomfort? We can't answer that question, but we can sort of look at what her dose might have been. So one of the questions that comes up is, where did the 1.3 come from anyway? So I looked back over the derivation of this, and it turns out that the copper lead rule, which was put forth around 2000, came up with this action level of 1.3. So where did that come from? So it turns out they looked at some studies of people with acute GI side effects, and some people were given copper and actually monitored when they got sick. But there were also some case reports of groups of people getting sick and their level of water. But bottom line is when they looked at this, they saw that some of these people that were getting sick had water at 5.3 milligram per liter. So maybe they were drinking 2 liters a day, which was why we've come up with this level of 10 milligrams or 10,000 as maybe the upper limit or where people might get sick. You remember I mentioned that before. So it's not a like really strong database, but this was something to begin to work with. So they thought, all right, we're going to cut that in half. And then because there might be children or others who are affected, we're going to put in even a further a safety value and cut that in half. So that's how we come up with 1.3. So it doesn't net, when you look at that, you realize that even if you're a bit above that, you may not be within the realm that could cause severe problems. And if she drank 2 liters from her water at home, maybe she's up to 4 milligrams. But of course, it could be cooking, other things. So it's possible she got a little discomfort, but we're certainly not in a huge amount over time. And because it's rapidly excreted, it's really doubtful she's having any storage of any excess copper, and she doesn't have Wilson's disease. And also, again, looking back at when she had the elevated transaminases, it did not occur when she was drinking the high copper level. So we went over all of that with the patient and her mother, and I think they felt reassured after that point. So what are the takeaways from this? And I think this will come up for us because we are dealing with patients on the environmental side who will come in with the tests of their water and be concerned about things. And that in this case, the EPA water standard is put forth to prevent gastrointestinal effects, and it has a safety range to it. And if somebody has mild elevations of their water, to be able to tell them what are the likely health effects and that they're not going to end up like somebody who has Wilson's disease, when you go on the internet, neurologic and all these kind of problems that most of us will be able, within reason, if it's a mild elevation, to deal with it and certainly to have it corrected and certainly to have the pH of the water corrected. We generally do not want to have acidic water because it's going to leach out copper, and if we happen to have lead, other metals. And so the other takeaway is that chelation is almost never indicated in these situations of potential copper excess.
Dr. Goldman, really
Yeah,
quickly before you go to the next patient, a
yeah.
question came in the chat about in terms of the treatment and everything. What did the daughter want for the treatments? I know you mentioned the mother was very
Yeah,
concerned about things, and
the daughter was a bit more chill. The daughter, if you want to know the truth, she was mostly concerned about the hives. And
okay.
uh, and to tell you the truth, that was very intriguing. Chronic urticaria, it's really tough. For
Right.
some reason, her allergist said she shouldn't be tested for things, which I didn't quite understand. So I said, well, maybe she should have more allergy testing. And with chronic urticaria, I did not find thank you for that question. I did
Mm,
not find a relationship to copper, my mild
mm,
copper. And
right.
even if it were there, she hadn't been exposed uh, after that. There are some issues with people having reactions to IUDs that are copper. Um,
Mm,
uh, but I couldn't, she was on birth control pills, I think, not IUDs, and she wasn't taking them then.
okay.
So it's a really good question. So for I never could say a definitive yes or no, but I was quite doubtful that
Mm,
exposure to the water, copper, was related to her hives. And what I recommended was that she revisit it with the allergist. For some reason,
mm,
they didn't do any allergy testing and just assumed she had chronic urticaria. So I'm not quite sure why
okay.
that was. So I
Mm,
referred her back
back.
to
Okay.
that. But that's a good question. Thank you for
Thank you.
asking that.
Of
That
course.
was her major question.
Yes. Okay.
Okay, moving on to the last patient, patient number three. And I want to give a shout out to Dr. Jeremy Berger, a resident who saw this patient with me a couple times at the clinic and helped put together this summary of her history. Anyway, this is a 72-year-old woman with chronic kidney disease of unclear etiology who's on dialysis, and she had developed a severe anemia that at the time was of unknown etiology, and she had to go in and get a number of blood transfusions, and it was not an iron deficiency anemia, even though I think they may have given her iron too. Anyway, in addition to this severe anemia, after some months of that, she then began to develop a progressive loss of sensation in her lower extremities, difficulty walking, despite the fact that her muscle strength appeared to be pretty good. And on her physical exam, she had a profound loss of sensation, vibratory sense in the lower extremities, and inability to stand. So she and her husband, she has a very devoted husband. They went to one doctor who thought it was in her cervical spine and she should have an operation. But he wanted a second opinion. So he brought her to a neurologist and she had a further evaluation and an MRI showing extensive non-enhancing signal abnormalities all along the dorsal columns, the entire length of the spinal cord. Her EMG nerve conduction studies confirmed this myeloneuropathy. And normally, this is the kind of thing we'd see with B12 deficiency, but they checked B12 and the folate, that was normal. So somebody who was really smart or knowledgeable in the hospital, I would not have known personally to ask this question, now I do, asked her if she had dentures. And it turns out she has an upper denture and she was using a dental cream that contains zinc. And at that time, they then tested the patient and found that her zinc level was elevated to 144 and her blood copper was undetectable. And so she was admitted to the hospital. She was given infusions of copper intravenously and then followed by oral supplementation. She stopped the dental paste. Later on, we found she was still taking a multivitamin with zinc. And basically, after the hospitalization, um, I was talking to the toxicology fellows because we talk about this, the patients, and the toxicology department doesn't really have outpatient in the Harvard system here. So she came to see me in our occupational environmental health clinic with the toxicology fellow on occasion and Dr. Berger. And anyway, that was the reason for that was she still needed monitoring of the serum copper, her zinc, when should she stop the oral copper, and what more should be done for her. So I continued to see her in our clinic. And within 4 months, this mysterious anemia had pretty much resolved and markedly improved, actually. It resolved over the time I saw her. And eventually, she normalized on the copper and zinc levels. She was getting extensive physical therapy. And I followed her for about 8 months. And then by that time, the anemia had really quite stabilized. She was just starting to get more energy and to begin to feel a slight sensation in her soles. I mean, it was pretty remarkable to do the physical exam. It was like the classic, a posterior column kind of situation. She had absolutely no sensation or awareness when she stood where she was standing in space. And she wasn't able to stand independently yet, but she was making progress. And unfortunately, around that time, she was found to have squamous cell carcinoma of the lung, and she died within a few months of the last appointment, sadly. But I want to talk about this is the most serious, I think, complication related to copper, and that's copper deficiency, which frankly I was unaware of. And by the way, when I went back over all of her records, because she was on dialysis, I guess there's concern about zinc deficiency. Zinc levels had been done for a long time, for months, and found to be high, and it didn't seem to trigger any action. And so I think this raises my final points that I want to talk about here, and something that I think is quite relevant, which is that zinc excess can lead to copper deficiency with terrible outcomes. And why does this happen? So both zinc and copper are absorbed. When I talked about that whole study where the zinc and copper have to come through the jejunum, and when they come into the jejunum, they're sort of bound to the metallothionein. But it turns out that copper is bound more tightly, but that when either zinc or copper comes in, and there's a lot of it, the zinc also stimulates, when you have a lot of it, more metallothionein and metallothionein to bind tighter. But it binds the copper tighter than the zinc. So what happens is it binds the copper, and the copper ends up staying around in the jejunum instead of being put into the blood. And then it's trapped there. And then during the normal, turnover of the enterocytes, it gets sloughed off and they go into the feces. So the copper doesn't get absorbed adequately and it goes out in the feces. And with our patient, it must have been going on for a long, long time for her to get to the point of no detectable copper. And just to recap some of the things we said earlier, why this is so devastating, to remember that copper is this essential cofactor for ceruloplasmin and another agent, hephaestine, which are involved in the mobilization of iron from its storage site and iron metabolism and the maturation of blood cells. So copper itself is very integrated into the process of creating hemoglobin and mobilizing and utilizing iron. And remember, they were all sitting up there together on the periodic chart. If you did a bone marrow biopsy, which I would hope people wouldn't have to do if you figured this out, but you would see a dysplastic myeloid precursors, vacuoles, in the erythroid and myeloid cells, ring sideroblasts. And frankly, it could look like a myelodysplastic syndrome. And I wonder how many people who are presenting with this, actually have a copper test, a copper and zinc. Before I knew this patient, I'm not sure I would know that. Um, So you can also develop neurologic problems because the now, and actually this was only described, I've been reading a lot of articles about this about 10 or 15 years ago, now described a copper deficiency myelopathy called CDB, which resembles subacute combined degeneration due to B12 deficiency. Copper is a required cofactor, as we said in the beginning, for many enzymes important to neuronal integrity, mitochondrial function, antioxidant defense. One example, the cytochrome C oxidase, if that's not functioning, you're going to get impaired energy. And that's going to give the vulnerability of your longest myelinated tracts. Those are the ones going down to the feet. And that's the dorsal column. And that's why you get degeneration. Without the copper, you're not going to have a really good functioning of the copper zinc superoxide dismutase. And that's going to lead to more of this toxic superoxides accumulation, these toxic oxygen species, which the super dismutase transforms into a less toxic version of peroxide kind of thing. And then also the copper-related enzymes are involved in myelin, so you're disrupting myelin as well. Um, but why would somebody have excess zinc? Well, one thing is the dental paste. And frankly, again, looking at the literature, she's not the first, and we hope to write her up. But frankly, there's been about 8 or 10 reports. She particularly herself was using something called Fixodent, which on the label says it has 17 milligrams per gram. And I don't know how much you put in when you're putting it in your denture. She herself said that she didn't think she used it excessively. She only used the tube over a month. And the RDA for zinc is somewhere around 8 to 12 milligrams. The tolerable daily upper limit, you can look it up, is somewhere around 40. Some people say 50 per day. But if you take these excessive amounts every day over weeks, you can really probably cause issues. I've tried to further figure out what's going on with what went wrong with this particular patient. You know, if she used a 21-gram tube and it's got maybe 357 milligrams and she used it over a month. She was getting 13 milligrams. She took a vitamin. What could be the role of dialysis? I tried to look that up. Zinc usually is not added in the dialysate. It is true that dialysis patients are concerned about zinc deficiency, and some people take the supplement. So in the end, I'm not 100% sure what happened with her, but I will tell you that when she stopped using the dental paste, her zinc levels became normal. Was there more zinc in the dental paste than they are reporting? We're left wondering, and I'm also left wondering why we still have zinc in dental paste. As we know, some people like to take a lot of zinc for, I don't know, stopping a cold or just because they think it's a good idea. But I would be cautious with this. If we have patients, we always ask patients about supplements. I would feel much more cautious now about asking patients about what supplements they take and how much zinc there is in the supplement. And because I think people can sometimes overdo it. I think what are my takeaways? Excessive zinc intake or high zinc levels can really lead to copper deficiency and anemia and a neurologic condition resembling B12. I have to say I now personally will have a much lower threshold to actually ordering a zinc and copper level in ceruloplasmin for people who have anemias that you're not quite sure what's going on there. And I think it may be a good idea for people who are having abnormal bone marrows to also be sure that people are checking a zinc and copper level. So this was a big learning curve for me on copper and zinc, but I think in terms of thinking about what we do as occupational and environmental and putting that E into our profession, I think paying more attention to copper, both as it's in the water and its relationship with the zinc, is probably a really good idea. So here's a few general references, and I'm going to stop there and let me see if I can stop sharing. Yeah, let me see if
Thank
I
you.
can get into the stop
Mhm.
sharing mode.
Thank you so much, Dr. Goldman. What a
Can you do the
comprehensive.
stop sharing? Were you able to do it?
Let's see.
Wait a
Um,
minute, I'm trying to get to that place. Oh, here, you are sharing. Stop. Okay.
okay, perfect. Yes.
Are we off of it? Okay.
Yes, we are off. Yes.
Okay,
Uh,
great. Okay,
Thank
yes, I
you.
see you back. So
Perfect.
I'm
Yes.
I'm open for any other
Yes.
questions that may have come up.
Yes, please feel free to ask any questions, either chat or feel free to unmute as well if you have a question too. We have
I
about
just
10
wonder if
minutes or so.
anybody's seen anybody who's taking, the zinc supplements, and also for the people who are maybe other people who might be dealing with the water question.
Yes. Hi, Jamie. I see you have a question.
Okay, thank you. Thank you, Dr. Goldman. This talk is very interesting. I can't turn my camera on, unfortunately. Um, so I had a question. I had a patient before that came in with an elevated copper level. And she was prior to coming to us, she was being treated by, I think, her PCP with zinc actually to lower her copper levels. And I was wondering if what your thoughts were on that, about like using zinc as a way to treat high copper levels.
Yeah, well, I guess the first question is why she has a high copper level.
Mm,
And that would be my first question. I mean, zinc would normally not be the way unless she's zinc deficient. So I would have to go back and also look at how high really was it? Was there ceruloplasmin? What was the ceruloplasmin? Does she have Wilson's disease, or is she on birth control pills?
mhm.
I didn't do a big deep dive into that because the patient I saw, I think, had stopped it, but there may be. Um, some interaction when you're on birth control pills to perhaps change with the copper levels. I'd have to look that up, but I would have to say, how high was the copper and why did she have a copper level done in the first place? Do you know?
Yeah, she was having some, um, sorry, this was the case from a while back and I hadn't looked it up before, but I think she'd been having some neuropathy and her neurologist got copper levels looking for copper deficiency, I think. Um,
Good.
and then
And
found that it was elevated.
oh,
And then had been getting serial copper levels. And our thought was that they were related to like hormone replacement therapy,
yeah.
postmenopausal like hormone replacement therapy. But prior to that, she was being treated, she had like slight zinc deficiency. So a slight zinc deficiency. So they were giving her
Right.
zinc.
Sure. Well,
Well,
if you have a zinc deficiency, then your copper levels might be a bit higher because of the two
mhm,
are, interacting with each other. So if she has zinc deficiency, one has to ask, why is that? Because it's in
mhm,
so many foods. And you could, I mean, zinc is in a lot of foods. You could be vegetarian and still have plenty of zinc.
mhm,
So I think a closer look at why she had zinc deficiency. But if you have a high copper level, I have not heard of treating it with zinc unless you have a low zinc level. My thought would be to look why she's having a high copper level, and I agree with you. I'd think about the hormones.
mhm. Okay. Thank you, Dr. Goldman.
Yeah, and I don't think it would be the low copper that would be related in most cases to the um, neurologic conditions.
Mhm.
Mm.
Yes, that's why, yeah, her neurologist was surprised when the copper levels were not
I'm
low.
glad the neurologist thought about it. I think, to tell you the truth, the last years, this copper related neuropathy has become more known.
Mm,
So I'm
thank
really
you.
glad to hear that a neurologist was looking at that.
Mm.
Thank you.
Thank you. Other questions, please feel free to either place in the chat or unmute. Um,
Oh, the weather. I saw Susan's
Other
weather.
Susan, yes, yes. If
Her mother came with her. There was just the two of them that were living in this apartment, and I checked the mother out. So I had a double header that day. They both came, and my recollection was that the mother's numbers were all normal. But of course, the mother didn't have this long. I mean, the history of it. But in the mother's case, her exam and her levels were normal, and she had many other symptoms, but they weren't related to copper. But good question.
Another question, Dr. Goldman, about for case three, if the MCV, the mean corpuscular volume, was helpful with that anemia
Good
determinant.
question. My recollection, maybe Jeremy remembers, was that it was normal, or it was either normal or slightly small. But it's fascinating that she got all these blood transfusions in the years before, and her husband said, and I don't know why, maybe they thought it was because she had kidney disease, but this didn't come up. She just got all these transfusions, and frankly, the anemia totally corrected once, which was pretty amazing. Once she was given copper.
I had a question for you, Dr. Goldman.
Yes, please.
Sure.
Thank you for the presentation, by the way. That was marvelous. I've been curious as to, we're in this era of very rapid fat loss products, GLP-1s, a surge in ice bathing, well, which increases fatty acid metabolism, or suspected to, right? With rapid fat loss, and I know toxicity, there's a lot of accumulation in fat lipids, retained fat. With excessive or rapid fat loss, do you see any metal toxicity or an increase in cases of, um, yeah, I guess metal toxicity or increased metal content
Yeah,
during
turns
labor?
out that's a really good question. But one of the reasons, one of the places for the problem with either low zinc or copper, people who've had the banding or the operations for weight loss, they're very carefully watched for zinc and copper. Those metals don't store in the fat. Like I said, with copper, it's more a little bit in the liver, but amazingly, the body eliminates and takes in just about the amount that it needs. Now, with rapid fat loss, what is an interesting component of your question are the agents that are stored, chemicals that are stored more in fat, like the PFAS, things like the old Agent Orange pesticide. There are certain chemicals that are stored in fat. So it is an interesting question that if you have these chemicals stored in your fat and you have rapid loss of fat, what's happening with those? Are those going out or just moving around to other storage sites? Really interesting question to which I have no answer.
But it would mostly be non-polar species that would be stored in fatty
Yeah,
tissues.
it wouldn't be the metals tend not to. Even if you look at lead in breast milk, it's a little bit that gets in there. It's not nothing, which the breast milk has a lot of fat, but it's more the fat soluble chemicals that get stored there or in the fat. So it's more the chemicals that are either fat soluble or fat binding, whatever those are. But the metals tend not to be that
Understood.
much. Not, but it is a very interesting question about what else is happening with all this rapid weight loss. And it's certainly been a big issue for the people that have had the operations because they don't absorb, in that situation, they're not absorbing things. I mean, another question that you're asking, I mean, that raises is whether or not when you take those GLP and it decreases your appetite, is it affecting anything in terms of absorption of zinc, copper, or the things? Because that's all happening at the jejunum and all that. And I don't know, actually. It's a great question. So maybe somebody can look that up and figure it out.
Wonderful. Well, thank you.
Thank you. There was a comment in the chat too about Dr. Goldman of how they're they, look at copper bracelets and copper vessels for health reasons, whether it's arthritis or other things. I just see that trend myself too.
Yeah, well, it does good things. I
Yes.
mean, it promotes energy. I mean, who knows what it's doing? I mean, if you look at all the positive things copper is doing, if you have the right amount of it, I mean,
Right.
who knows? Because it definitely is important for energy production and for getting rid of those toxic oxygen radicals. Now, how it works on a bracelet. I mean,
Right.
I don't know. Um,
Mhm.
and actually, with the IUD, I think
Mhm.
what happens there is the acidic environment or something. It releases some copper ions, and
Mhm.
that has some effect on um, the hormones and things like that. So
Right.
it's a very interesting metal, and I think we should be paying more attention to it.
Right.
It's not
Mhm.
been one I've paid a lot of attention to, and I just bring it up to people
Yes.
because I think it has some really good lessons and also lessons about the levels. And just wanted to point out when you get these water tests, how to interpret it.
Mhm. Right, right. Well, thank you so much, Dr. Goldman, for such a comprehensive and important presentation. Like you said, I think it's something we should all be paying more closer attention to, and kind of the spirit of, why we thought to, bring seminars like this. So, truly thank you, Dr.
Thank you.
Goldman, for this.
Thank you for inviting me. I'm appreciating sharing. So I'll mute myself because I think you need to go on.
Yes, yes. Thank you so much, Dr. Goldman.